Okay, so the patient is 65 years
CPP
old male,
price
and
pressure.
the patient complained of the chest tightness and
Sorry.
shortness of the breath for many
Wait.
years,
Wait.
and dyspnea for 1 month, and there is a rough systolic murmur in the aorta valve, and the breath sounds in both lungs are coarse and wet rates can be heard. And also the risk indicates that the
No.
patient have the hypertension for 10 years. We can see the angiography about the coronary condition, and it shows the max plaque in the proximal wall of the right coronary artery, RCA. It shows the severe
Stop.
stenosis of the vessel.
Stop.
And about the middle wall of the RCA, it's a mild vascular stenosis. And the distal wall of the RCA is moderate stenosis. And the next we can see, okay, yeah, sure. It's RCA, the moderate and the mild condition. Okay, great. And the next, we can see the CT imaging. The CT analysis shows the aorta is a type 0 BAV with a calcium score of the 527. And it's a moderate to severe classification. And we can see the classification is focused on the between the leaflet. Okay, and the next it's about. Oh, sure. We can see the CT analysis video, right? It's from the it's based on the aorta route from the subvalvular VOT 5 millimeter to the annulus plan and to the supravalve plan to AAO. And it shows type 0 and the LVOT open dilated. And for the LVOT 5 millimeter plan, it shows the perimeter is 33.4 millimeter, and the STG is 35.7 millimeter, and the SOV is the mean value is 29.3, and the max is 21.7. And we can also see the annular parameter is 27.9. It's a little large, right? Okay. And we can also see the AAO 40 millimeter. It's about almost 40 millimeter. Sure. And we can also see the angle between the annular plan and the horizon plan, and the degree is 55. It's it's almost transverse hard. Okay, so the next, okay, and then we can see the coronary condition. It's the coronary analysis, and it shows that under CT, the leaflet length was less than the height of the coronary outline, and with the overall coronary risk was low. It's fortunately, right? Okay, and the next is about the multiple plan analysis about the CT imaging, and we can see the supravalvular multiple analysis and the classification mainly on the lateral side of anchored leaflet and focus on the edge of the leaflet. And the supravalvular restriction zone was from 4 to 10 millimeter supravalvular. And for the supravalvular 4 millimeter plan is the parameter is 26.7 millimeter, and about the super millimeter plan is about 25.6, and we can see it's the restriction range about the supravalvular situation. And so, depends on the situation, we choose the tourist artery from Peijia Medical, the balloon. And the balloon size is 22 millimeter. And actually, the Peijia Medical is a domestic Chinese company and was selected for the balloon pre-dilation. The valve strategy, we choose the Taurus Elite AV29 valve. It's also from the Peijia company. And we can see the next. Okay, maybe something. It have a problem about the PowerPoint. So maybe wait 1 minute. Okay. Oh, okay. Now we can see that. Great. It's about the projection angle about the CT imaging, and we choose two angles, and one is about the projection angle, it's IO 30 and RAU 28, and another angle is also the insurginal position, it's about the LAO 33 and CRA 35 for variation about the valve release. Okay, and okay, the next we will see the access analysis, and the access analysis shows the good condition about overall valvular size and shows the insertion to avoid damage during operation. Okay, let's go to the next slide. Okay, now we will do a conclusion and our treatment strategy, one-stop procedure about the TAVR and the PCI. And our TAVR strategy is about we use the 22 PCI medical balloon do the pre-dilation, and we use the toricillate AV29. And for the PCI, we do the LCX and RCA and treat it with DES or DEB and assist with CPB.
Of course, our PCI procedure is performed under the guiding of the intravascular imaging with IVAS. Then we finished the PCI procedure for the circumflex lesion, and we implanted two DES from the distal to the proximal segment of circumflex. And the final angiography result is also very excellent. Next, we will perform a TAVR procedure.
Okay, we will insert 20 French introducer sheaths into the right femoral artery main access, and administer the anticoagulant heparin and check the activate clotting time ACT after the initial heparin push, and recheck every 30 minutes thereafter. Maintain ACT more than 250 seconds. And advance the pigtail catheter to the ascending artery and position the distal tip in the long corollary cuffs of the native aortic valve. Identify the ideal annular viewing plane using the contrast injection at various angiographic angles.
Yeah, Dr. Sun just successfully transvalular used the GetWare and used the AL catheter. And now we will exchange the GetWare, and we will change the straight GetWare to the G-head GetWare. And we will also exchange the catheter, the AL catheter, to the pigtail catheter. Okay, and the Dr. Sun has finished about the step, like the exchange the catheter from the AL1 to pigtail, and use the pigtail to do the blood pressure test, and the blood pressure test shows it's great, it's stable. Okay, we can wait.
Lead shoot. Open. Okay. Now we can scream. After the press of the airway button and press pressure of the AO.
Great. Fortunately, now our angiography have aligned to the DSC with angiography. We have called the engineer and we repair that. And now we use the pigtail to do the angiography, and we can see the situation about the aorta root.
Lundquist required, maybe. Lundquist may be required.
And from the angiography, we can see the classification situation and the restriction.
Maybe.
Condition is almost same like the CT analysis. It's the restriction range is from the 4 to 10 millimeter. And now we will exchange the guidewire. We want to exchange the guidewire to Lundquist, the super stiff guidewire.
Open Lundquist. Another.
Yeah, thank you, Professor Tu. And for these patients, we do so much CT analysis before the operation. And we do this strategy based on these patients have a BAV valve with annulus of 27.9 and from 2 to 10 millimeters supravalvular anchorage interval in the range of the 24.7 to 27.3 millimeter. And based on the annulus and supravalvular restriction,
29.
we measure the AV29. Yeah, the AV29 valve oversize as 9.3 to 13.2%, and AV26 at 0.9 to 5.2%. So we choose the Torres, or we choose the Torres Elite valve, the AV29.
Now, now we check the valve.
Yeah, now the Torres Elite, the valve delivery system has pushed into the access.
Okay. Low.
Okay, we have checked the aorta delivery system under the DSA. So we will follow about the last question is about choosing the balloon size, right? Okay, and in inner operation, we will also verify the degree of the supravalvular restriction and the valve strategy selected by balloon sizing for the validation of the degree of the supravalvular restriction and the choice of the valvular strategy. Yeah, Dr. Sun.
Hello. Now, we will balloon dilation. Now the CPB is start. Okay, CPB start.
Okay, great.
Good luck.
And now Dr. Sun will do the balloon pre-dilation. And Dr. Tu, would you like to introduce about this procedure?
For this patient, and which special valve system do you want to select, Professor Liu, and why?
Yeah, like I said, we choose the Torres Elite AV29 valve for this case and use the balloon size like the 22. Because we found that they have the moderate to severe classification situation from the 4 to 10 millimeter supravalvular analysis. And we think if we want to reduce the risk of the leaflet tear, we need to maybe adopt a small balloon pre-extension strategy. So we choose the 22 millimeter terrace artery balloon. So that's the reason.
Yes.
Okay, now we start the balloon dilation.
Okay, hello.
And we think it's not stable, and we will wait for that. We will wait the ventricle to be stable, and now we try again. So we want to find an ideal position for the balloon dilation. Okay, from the angiography, we think this balloon dilation, the performance is great. Do you think that, do you like the same comments, Dr. Sun? Do you think the balloon dilation is great?
Pacing stop. Okay.
So, Dr. Sun, do you think the balloon dilation performance is great?
Yes.
Fantastic.
Performance.
Yeah, the performance is great.
So we choose the valve size 29.
Okay, and now we will do the Torres islet the delivery system for the AV29 like we did the strategy before the operation.
Last picture.
The last picture, okay.
Okay, last.
上一张图怎么上一张图调一下，这个是怎么调的？我看上一张图，我知道。
Constrict the flute. Date the constrict flute. Yeah.
This one, right?
And next.
The next, right? Okay, the next.
Okay, yeah.
Okay.
Okay, from the angiography results, we find that there is no coronary artery occlusion and no obvious leakage. Additionally, you can see the obvious balloon with the sign. So we choose a 23 millimeter balloon pre-dilation strategy is reasonable, I think.
Yeah, I agree with that.